So welcome again. Hopefully a lot of you are coming for the second time, third time, or multiple times. Pleased to say that today we're having a fantastic course on hypercalcemia and parathyroid disease by a colleague and friend of mine here in Oxford, Shad, who is a consultant in general and but an expert in endocrine surgery. So I'm looking forward to a fantastic talk by him. Please, can I just say, ask as many questions as you like throughout the talk, and I can put them to Shad at the end of the talk. And I'm sure he'll do his best to answer as many questions as possible. I'm not going to talk much more, but I'm going to hand over to Shad to give his presentation. Thanks very much, Shad.
All right, great. You can hear me all right?
Yeah.
Excellent. Thank you, Charles, Royal College of Surgeons, Mike, for this opportunity to talk to you again. As mentioned, we're talking today about hypercalcemia and parathyroid disease. It's a continuation from our talk from a couple of weeks ago about neck lumps, and we'll get going. So hypercalcemia, a very common electrolyte disturbance. You'll see it in all fields of your specialty, wherever you end up in. Very important to know what to do with it and how to take it forward. In hospitalized patients, hypercalcemia usually means some sort of occult malignancy. And in primary care outside hospital, it usually means primary hyperparathyroidism. There are a few other examples of what can cause hypercalcemia, and you should be aware of some of them. I know that, unfortunately, not everyone falls into those two first categories, and there are other causes of hypercalcemia. So a little bit about parathyroid disease, first discovered in the rhinoceros back in 1849 by Richard Owen, pictured on the right. It was later discovered about 30 years or so on by a medical student, a Swedish medical student, Victor Sandström, who found it in humans. It's known as the last major organ discovered in humans. The bottom is a picture of a rhinoceros's thyroid and parathyroid, just labeled there. So a little bit about the anatomy of the human parathyroid. These are usually four small tan-coloured glands that sit right next to, as the name suggests, right next to the thyroid gland. They arise from the third and fourth pharyngeal pouches, and they measure a bit of variability, but usually about 3 by 5 by 3 by 1 millimetre, and weigh about 30 to 35 milligrams. They're, as the picture suggests, just found on the posterior to the lateral lobes of your thyroid. And there can be some variability with people having 3 or 5, or sometimes even more parathyroids. A bit about that dreaded microanatomy. They're mainly made up of these chief cells. These are what produce and contain the PTH. They also have these oxophilic cells, which tend not to have that much purpose with regards to endocrinology. Water clear cells, which are a type of variant chief cell which store the glycogen, and the whole thing is surrounded by fat and a thin fibrous capsule. And that's quite important, because when you start to see thick fibrous capsules in parathyroid, that might underline some sort of cancerous process. A little about the physiology. The parathyroid glands secrete PTH, that's parathyroid hormone, which is a small polypeptide with a very short half-life of around 3 to 5 minutes. And that becomes very important because we can utilize that fat a little bit later when we're operating. It's about 84 amino acids long, and there's a picture of it shown here. And their main function is to control the serum calcium and, to a degree, phosphate levels through their actions on bone, kidney, and the intestine. So the physiology gets complicated, but it's that lovely negative feedback system that we love in endocrinology. PTH and vitamin D are both needed for calcium regulation. And it's important to have an idea as to how this all works. So PTH functions mainly on the bone to help release calcium and phosphate into the bloodstream. It also has an action on the kidney. Has 2 main actions on the kidney. First is to try and increase calcium reabsorption from the distal convoluted tubule. And then it helps, as this diagram shows, to convert 25 vitamin D into 125 vitamin D, which is known as calcitriol, which is the active form, and that has its own actions, mainly on the bone and on the intestines, to help increase serum calcium. Vitamin D gets into the body through dietary, but also through the skin, where sunlight hits the skin and converts the form of cholesterol into vitamin D and starts to cascade, where the liver then converts it into 25 vitamin D, and then, as you can see, the kidney into 125. This is all antagonized by a hormone called calcitonin, which is produced by the thyroid gland, and it's the parafollicular C cells of the thyroid gland. And just to give it some sort of context, it's these parafollicular cells which, when they become cancerous, give us medullary thyroid cancer. So that's all when it's working well. But of course, sometimes these things don't work so well, and we get pathological changes, and we can get hyperparathyroidism. It gets a little more complicated here, and we know that there are primary, secondary, and tertiary types of hyperparathyroidism. We're going to concentrate mainly, and you can see on this group over here, of primary hyperparathyroidism. But you should know that there is secondary, where you have hyperparathyroidism in response to something else, and tertiary, which we see in our chronic renal failure and transplant patients, where you get an autonomous production of parathyroid. So primary hyperparathyroidism, it's an inappropriate increase in PTH secretion due to pathology of the gland itself. And these can arise from adenomas in the vast majority, where patients have usually one, but sometimes can have two adenomas, or a hyperplasia, where the glands themselves get a little bit bigger in size and therefore increase in their activity. Very few can be caused by carcinomas of the parathyroid gland. You'll be aware from your training of this multiple endocrine neoplasia, which I won't go into today because there is another talk, I believe, coming up in a month or two by one of my colleagues. But just to be aware that in young patients, primary hyperparathyroidism may be due to a genetic condition such as MEN. So the presentation is varied. Calcium works on so much of the body, it can present in many, many ways. And hopefully you might be aware of the adage, stones, bones, groans, and psychic moans, where stones, it can give you kidney stones. Bones, you get aches and pains in your bones, as well as increased fragility and fractures. Groans refers to abdominal pains, constipation, pancreatitis, and psychic moans, confusion, depression, and fatigue. The way you would investigate these is to perform your blood test, looking for an elevated serum calcium, an adjusted serum calcium, as well as an elevated PTH, which would give you your probable diagnosis of primary hyperparathyroidism. We always advise checking the vitamin D levels to ensure they're not low, which might be elevating your PTH. And it's always a good idea to check your urinary calcium. You might be familiar with this condition called familial hypocalciuric hypercalcemia, which, as the name suggests, is a genetic condition where you excrete very low volume of calcium in your urine, and it can give rise to high calcium and high PTH. But because it's a genetic condition where your body is not sensing, your calcium sensors are not working properly, this does not need any operations to cure it. It is a completely benign disorder. I'll quickly mention about the acute medical management of these people, because it's important to note. Calcium of less than 3, so between 2.6, which is the upper end of normal, and 3 are often asymptomatic, and they just need referral, diagnosis, and treatment. And they won't have the severe medical emergencies, which we're worried about. Between 3 and 3.5, we start to get a little more concerned and worried, and these people sometimes do need inpatient management. And above 3.5 millimole per litre, this is a medical emergency and needs immediate treatment because of the risk of dysrhythmias and short QT intervals and things like that. So the first line treatment is increase your oral fluid. So everyone is told just to drink 5 litres a day as much as they can, but that's quite difficult to do. And these people will come in very thirsty, often drinking a lot already. They will often need IV rehydration, most commonly with normal saline rather than Hartmann's, because Hartmann's does have a small amount of calcium in it. Second line, we often give them bisphosphonates, such as pamidronase, and these work by inhibiting the bone resorption. It's important to know whilst they start to work straight away, their peak is at about day 2 to 4, and they carry on working for a good few days. So it's very important that if you give someone bisphosphonate, you cannot refer them straight to have an operation within that first week or 2, because assuming your surgeon then goes and cures them, that pamidronate still circulates around, and their calcium drops dramatically and dangerously. The third line are calcimimetics, such as cinacalcet, which mimic calcium at the PTH receptor and can be a very good way of controlling calcium while you're waiting for an operation, or in someone who's not fit for an operation can be used to help keep those levels a bit more reasonable. Other methods, such as calcitonin, steroids, and dialysis, are used by specialist units and on the case-by-case selection. So imaging. Now, this is very important, and I rant on about this quite a lot. In almost all endocrine disease, you only start to do imaging once you have biochemically proven the disease. And you're now looking, and the decision to operate has been made, and you're now looking to try and get a bit more information. If you're thinking your patient's not safe or cannot have an operation due to severe cardiac or respiratory problems, there's no point doing the scan. You've got the diagnosis, there's no point trying to localize it any further. Or if you're not sure of your diagnosis, you don't do a scan to try and confirm it. That's not how endocrine diseases work. So the gold standards are usually an ultrasound scan, which is cheap, quick, and easy to do, and can give us a lot of information. I know a lot of units who use that as their only modality and have great results. Sestamibi and SPECT scans start to use tracers to give us some sort of cross-sectional imaging that help us localize these. We'll go on to those in a minute. MRIs are much more third or fourth line, and they're usually quite good for looking at parathyroid, ectopic parathyroid.
I'll apply and I'll let you know.
Which might not be within the neck, but might have descended down into the chest. And in cases of redo surgery, where, for example, it's a patient's been operated on, hasn't been cured, and needs another operation, it's a good idea to either get a PET scan or a venous sampling, depending on the unit you're in. PET scan, again, uses a choline radioisotope to help localize these glands and has very promising results. And venous sampling is when we get our radiology colleagues to go in to take blood samples from various places around the neck, and we almost form a venous roadmap of the neck to try and see where the PTH levels are highest, to give you an idea as to whether the patient is more likely to be on the left or the right. So here are some images, because those are always fun to look at. An ultrasound of the neck. Here we can see the trachea in the middle, this lovely shade of the thyroid over here, above which is the sternohyoid and sternothyroid, your strap muscles, and the sternocleidomastoid. Very obvious and easy to see the jugular, which when you're with an ultrasound, you press down and you'll be able to see it compresses, and the carotid artery, which doesn't compress. And just behind the thyroid, as you remember from the first diagram, you can see a lovely little parathyroid adenoma sitting there. The MEB scan, you give the radioisotope uptake, and immediately you can see everything lights up: parotid gland, submandibular, and the thyroid. The funny thing with the parathyroids are they have a delayed washout. So when you do another scan in 3 hours' time, the thyroid has emptied out all the radioisotope, but you've still got this little shimmer of something in the left side of the neck, which suggests suggestive of a parathyroid tumor there. The SPECT CT is shown over here, which doesn't need much explanation. The radioisotope gets taken up into the gland and lights up. And then we have some 4D imaging, reconstructed imaging, which shows a lovely parathyroid adenoma. So surgery, very important to know that surgery is the only cure for primary hyperparathyroidism. The aims here are obviously to find and remove the offending glands and to preserve neuronal function. You can see from this diagram here, we have a parathyroid just here, and we have another one just here. And the recurrent laryngeal nerve is in real close proximity to both of these. And it's very important during surgery to find your recurrent laryngeal nerve before you do anything else. Find that so you can preserve it as you're doing the rest of the operation. Obviously, you want to avoid removing any normal glands because that risks hypercalcaemia that the patient shouldn't need to undergo. Surgical approach can be open. It can be a minimally invasive focus approach where if your scan has shown you've got a big tumor on one side, you can just target that rather than looking for all 4 glands. Or there are some places in the world which give keyhole with varying results. So the parathyroidectomy, I'll very quickly talk you through. You give a skin crease incision. You elevate the flaps as shown down here, where this is the platysma muscle. Just go through that and elevate those. And then you'll find your strap muscles. You go down, open down the midline of the strap muscles and delineate your thyroid gland, after which this picture shows a thyroid gland which has been mobilized. And hopefully somewhere around here, you'll see a parathyroid around the back here, and possibly another one down here. So we'll get some nice pictures later. You have to make that decision yourself on your own unit and your own expertise as to whether you are going just on one side whether you're going to just explore the one side that the scan suggests, or you are going to go then open the other side of the neck and look for those glands as well. And that's on a case-by-case basis. Personally, if you have a good scan which shows you have a parathyroid tumor on one side, I would explore that side, remove that tumor, and then possibly look for another gland on that side. And if I think that looks normal, then it makes the possibility of hyperplasia less likely, and you might decide to stop right there. If, of course, your scan has not shown a parathyroid tumor, you'll almost need to go and look at all 4 glands yourself with your own eyes and decide which of the abnormal ones there. Some pictures intraoperatively that I've managed to locate. Here you've got your thyroid gland being retracted, and just behind there you've got a recurrent laryngeal nerve just sitting there. And here's a lovely picture of a little parathyroid. And again, here's a picture of a parathyroid, rather large parathyroid tumor, which has been done keyhole. The final product, I must say these are not because the surgeons are amazing at stitching neck all the time, but this is more because the neck has these lovely natural skin creases, and if you can get your scar into one of these, it just dissolves away into a lovely scar. That's not always the result, and unfortunately you've got to pay a lot of attention to your neck closures, because obviously this is in the front of the neck, and you want to minimize scarring in this area as much as possible. But generally, they do tend to scar and heal up very nicely. So pathology at the end gets removed and sent off to the lab, where a pathologist will confirm that you have removed a tumor. The real confirmation comes from the fact that post-operatively your bloods become normal. This is the case on the right where hyperplasia was found intraoperatively and 4 glands have been removed, you can see. Now, you can't really live with the 0 parathyroid, so a small sliver of parathyroid would have been left behind, and that's sometimes all you need, just a small sliver or half a parathyroid in order to maintain your calcium at a reasonable level. So post-operatively, we talked about the half-life of PTH being 3 to 5 minutes. And this is very important because post-operatively, or in some units even intraoperatively, you can remove the gland and do a blood test. And that blood test can come back within a few minutes and tell you, yes, the PTH has started dropping already, which can almost give you an idea that you've cured the patient before you've actually stopped closing the skin. So most units don't have this facility, and you can do a blood test post-operatively so that before the patient goes home, you can let them know that they have been cured. A lot of our units nowadays are doing this as a day case. If you're getting it done nice and early and you're not worried about bleeding, then they can go home on the same day. We often check calcium after 2 weeks and then again at 6 months to check any recurrence. And we tend to do a formal voice function assessment to ensure there has been no occult injury to the recurrent laryngeal nerve. And again, just to reiterate, if you're under 40, consider genetic testing to make sure there's no other underlying condition. So hypercalcemia, usually due to malignancy or primary hyperparathyroidism, but there are other conditions that can cause this. Calcium over 3 need medical attention, and over 3.5 is dangerous. Confirmation of diagnosis, and if it is confirmed to be primary hyperparathyroidism, localize with imaging, and refer early for surgery. We still have large cohorts as we work with our local GPs and endocrinologists who we find patients are coming having been diagnosed with primary hyperparathyroidism years before, but don't ever get to see a surgeon, and only once they've seen us can they be cured, because there is really no other medical management for this condition. Good. I'll end the talk there, as I can see questions starting to come in, and I'll hand back over to Giles and Mike. Just to say, reiterate, guys, if you're thinking about asking a question, there is a very good chance many other people are thinking the same thing. So do ask anything you want, and we can try and go through as many as we can.
So Shad, fantastic talk there. Thank you so much for that. There's been some good questions, actually, some which may require you just to go over some of your previous slides, if that's all right. One of the questions was, where did it go? I thought it was brilliant. So what is the difference in biochemistry between primary and secondary hyperparathyroidism?
So say it again. What is the
difference in biochemistry, specifically, between primary and secondary hyperparathyroidism?
Let's see if I can get this slide up.
Did you get that, Shad?
Yeah, got that. Can you hear me?
Yeah.
Okay, great. So here we go. So the main way of looking at this, well, actually, it depends on what you use as your definition of secondary hyperparathyroidism. But the way we've described it here is to say it's a response of an appropriate response of increased PTH production by your body in response to a low calcium. So in any condition where your calcium is low for some reason, you might find that your PTH tries to increase in order to get your calcium levels a little bit higher. So in that case, you're finding your PTH your calcium might be normal or low with a high PTH level, but in primary, you're expecting both of them to be on the upside. Now, there are obviously there are things that break the rules, and there are subheadings within these that will make that a bit more difficult to understand. But generally, that is thought to be true. There are also conditions where you can get a normal calcium, but a high parathyroid. These normal calcemic hyperparas, which cause a lot of controversy and difficulty within our world, and it's getting probably a little beyond the remit of this talk.
Yeah, I think so. The Alice Hallam has put in a question. When you're doing these surgeries, how do you differentiate between the parathyroid gland and the thyroid gland during surgery? Is there any special techniques? I know you touched on it.
Yeah, great question. Excellent. Let me try and back it up with some pictures to be on. So it comes down to experience, I think. It comes down to seeing hundreds of these and doing quite a few and then just getting an idea. It's a very good question because when you're doing the other thing, when you're doing a thyroid operation, it's absolutely one of the things we crucially look for are these parathyroids so we can try and save them. There are, you find someone with hyperparathyroidism, severely affected by very high calcium, and they can be really symptomatic. But I can tell you now, the only thing worse than being severely symptomatic with high calcium is being permanently hypocalcemic, where your life depends on you taking calcium tablets every few hours of your life. So to answer your question, we look very carefully for all these glands, and with the naked eye, you should be able to find them. There are adjuncts. Methylene blue is still used, where you inject intravenous methylene blue, which helps light these up a little bit more. A lot of work is being done at the moment throughout the world on using ICG, which is a dye, and then use a special camera which helps highlight these glands a little bit better. But at the moment, most of us in most units are just using our naked eye to find these glands and using our own experience.
Fantastic. Just one more. If do you want to? There's a question. I'll just pick one out. Which one am I going to go for? The very quick one. Should low vitamin D levels be investigated with a calcium profile?
Yeah. They usually come part and parcel. Just remember one thing. This is going back a few years, but from memory, vitamin D is quite expensive as a blood test. So you don't want to just keep banging away at it and doing more and more of those. But we find a lot of people in the UK have a low vitamin D. That's for many reasons, mainly probably weather related. But it should prompt that just to make sure that your calcium levels are staying up. But it's likely if you've got low vitamin D, it's probably just an isolated low vitamin D, which we're taking as a supplement would be enough to get it back. It doesn't mean you've got any disease of the calcium or parathyroid. If you have a very low calcium, very low vitamin D for a long time, you might find that your PTH levels go up a little bit. And if you go back to negative feedback, you'll see why that is. But your calcium levels, which are usually quite well regulated, should remain normal during that time.
Final question, Shad. Are there always renal complications, manifestations with hypercalcemia?
They're not always. No, these are we go back to what are the common reasons. These are probably all very common reasons, but as you can see, things like depression, fatigue, joint pains are all very vague, and people can come in with them for many, many reasons, not just hypercalcemia. Renal stones can be made up of many different particles, and one of our things our urologists are very good at now is if they get someone, especially when there's someone very young with renal stones, they'll remove the stones, and where possible they'll send them for stone analysis. And depending on what the stones are made of, they can be made of all sorts of funny things. But if they find that they're very calcium rich, that might prompt them to get a calcium check and then refer to us if appropriate. So we do get a lot of referrals from our urology colleagues.
That's brilliant. Look, Shad, I think we could go on all day about this, but thank you so much for summarising up with what is actually a complex and vast topic. I really, really appreciate it, and I'm sure all the other viewers do as well. I will just use this moment to remind people that next week's webinar is acute appendicitis. For those guys starting their F1, it's an absolute must. You've